Thank you very much. Good morning, everybody. Dear Chairman, Professor Koch, it's my pleasure to be here. It's my third visit to begin to the Great Wall Congress. My topic, primary prevention of diabetes mellitus in cardiac health. It's one of the main topics of my research. I am professor of National Research Center for Preventive Cardiology in Moscow. This is located in historical city center. So, diabetes is a global epidemic for worldwide. About 6-8% of adult population is of world is diagnosed with diabetes mellitus. Firstly, this is a type 2. About 90% of all diabetes mellitus is a type 2 mellitus. And you can see this is a worldwide map. And here we can prognosis of increase of diabetes mellitus in Latin America, in Africa, and in Asia. China is the #1 country for the increase of diabetes mellitus. Near 10 to 20 years, it will be increase of the diabetes mellitus about 80% in China. So, causes of death in type 2 diabetes patients is the first is a myocardial infarction, about 55%, and the second is stroke, about 29%. And you can see this is a prospective study, nurses health study, is a cardiovascular risk on different diabetes stage, not only diabetes mellitus associated with increase of cardiovascular risk, but pre-diabetes period is independent risk of cardiovascular disease too. You can see here increase of cardiovascular risk in compared with patients without diabetes. So diabetes is another chronic non-infection disease. Have this continuum. This is a disease for 15-20 years. And this is slowly developing. All this process frames as a diabetes mellitus. Firstly, it's an increase of insulin resistance, increase of secretion of insulin, and also this synthesis of glucose in liver. And after you can see this is development of diabetes mellitus. So pre-diabetes it is annual conversion of AGT, to pre-diabetes to type 2 diabetes. This change, this depend of the population, is average about 4-5%. So previous speakers say about metabolic syndrome, and I would like to present too. This pre-diabetes and diabetes this is one of the component of metabolic syndrome too. This is a Riven. You see this is a Riven. He describes this metabolic syndrome in his Bantek lecture. Whether cardiologists should conduct primary prevention of diabetes or not. Yes, we have some arguments. First, there's a prevalence of pre-diabetes in the patients with cardiovascular disease. It's a famous Euro Heart survey. This is multi-center study, includes 110 centers in 25 countries. The prevalence of hyperglycemia among patients with acute coronary syndrome. We can see only 35% have normal glycemia. Other part have different type of the hyperglycemia. Is a pre-diabetes, red is pre-diabetes, diabetes about 25%. And pre-diabetes is impaired fasting glucose, and impaired glucose tolerance is about 40%. Second, impact of fasting glucose and 2 hour after tolerance glucose test on risk of cardiovascular death. And you can see after load glucose is independent risk factors for coronary risk. Is increased about 32%. Fasting glucose independent risk factor too, but the after load glucose level is 2 times more in development of cardiovascular disease. Is a main document for us, for example, for Europe and for Russia, maybe this is in SGS is adapted. This is some topic of the European guidelines. It's guidelines on diabetes, pre-diabetes, and cardiovascular disease. So this is the main topic of the pre-diabetes. Assessment of predicted type 2 diabetes risk should be part of the routine healthcare using the risk assessment tool available. You can see this class of recommendation very high and level evidence B. Patient without known diabetes will be established cardiovascular disease should be investigation on oral glucose tolerance tests, because about 60% of patients don't know about diabetes. People at the high risk of the type 2 diabetes should receive some lifestyle change, and if need, and sometimes we must use pharmacological therapy to reduce or delay of the risk of development of diabetes. This is a level of evidence and class of recommendation high. So screening approach, we have three type screening: population screening, selective screening, and opportunistic screening. So it's our own study. This is a epidemiological study in one of the cities of Russia. This is Volga district. You can see prevalence, all main risk factors in our Russian adult population. It's about 2,000 men, includes is not cohort, is an epidemiological study, and you can see arterial hypertension prevalence about 30%, total cholesterol, hypercholesterolemia 55%, triglyceride increase 25%, LDL cholesterol increase 36%, obesity about 20%, and the last in pre-diabetes, two type pre-diabetes, impaired fasting glucose and postprandial hyperglycemia, and totally is 8%. 8% of adult population have pre-diabetes. So second argument for high selective screening is the carbohydrate metabolism in the patients with arterial hypertension. First, third stage. You can see just normal glycemia. We defined just 40% cases of patients with arterial hypertension. Other parts have this different pre-diabetes or new diagnostic type 2 diabetes and type 2 diabetes. About 4% is type 2 diabetes. New diagnosis type 2 diabetes about 12%, and pre-diabetes about 33%. And a very good, very easy tool for prognosis of diabetes risk is a Finnish diabetes risk score, FinRisk. We wide use this tool for screening of our patients with different cardiovascular disease. Just 8 questions for determination of the prognosis of diabetes mellitus risk. This depends as low, moderate, high, and very high risk of diabetes mellitus. Also, we must use oral glucose tolerance test. And according to the oral glucose tolerance test, patients is divided some groups: normal, impaired fasting glucose, impaired glucose tolerance, and type 2 diabetes. You see this 3.0, 60 minutes, and 2 hours. Preventive strategy. We have two strategies. This is a population-based strategy involving altering the lifestyle and environmental determination of the type 2 diabetes. And the second, this is a high-risk strategy applying preventive measure on individual level. Type intervention. Behavioral interventions including change of diet and increasing physical activity and or pharmaceutical intervention. Some agents for improvement of glucose tolerance and insulin sensitive. And first, the lifestyle. You can see this meta-analysis of the studies with use is the lifestyle change. Is first is the European cohort. Second, this is the Finnish, and third is the United States, and I think this is China. And you can see when we use lifestyle, we can reduction of relative risk of diabetes mellitus about 40, 50, 60% is possible. So diabetes risk in randomized trials of antihypertensive treatment. This you know, this very popular these trials: HOPE, CAP, ALHAT, SCOPE, LIFE, VALUE. And when we use sartans of ACE inhibitors, we can see also they influence to risk of diabetes mellitus. The reduction of risk diabetes mellitus about 13–20%. So in some case we use anti-hyperglycemic agents too. For example, this metformin, acarbose, rosiglitazone, and you can see this DPP, DREAM, STOP, NEED, ACT, NO, Navigator studies. And these studies clearly demonstrate that when we use therapeutic doses of these agents, they decrease or reduction of diabetes mellitus risk about 30–50%. It depends which population and which dose. We have this my own experience for use of metformin and rosiglitazone in patients with metabolic syndrome without diabetes mellitus, pre-diabetes, with the pre-diabetes. It's a 3 months duration randomized this group, selective group with metabolic disorders and pre-diabetes. And one group receives rosiglitazone, and after 1 month we increase the dose of rosiglitazone, and metformin. This started about 850 milligrams, and after we increase dose of metformin, and this control group. And what's the result? You can see this result here. Fasting glucose, after load glucose, insulin resistance index, weight circumference, LDL cholesterol, triglycerides, HDL cholesterol change after these anti-hyperglycemic agents. Patients with pre-diabetes, it's not diabetes patients, it's pre-diabetes patients. Also, I think this Professor Koh will describe this statin status only in patients with type 2 diabetes, but we have our experience. Those depend influence of statins to the glucose metabolism. We can see this atorvastatin, 10 milligram, 20 milligram, and 40 milligram, and control group. And this is 6 months this study, and you can see in those depend influence of atorvastatin to glucose metabolism. When we increase this dose, it's influence to the glucose, fasting glucose level. Maybe this is a 10%, 12%, but the incidence we fixed. Also, we can see this HOMA index, insulin resistance. When we use more dose, high dose of atorvastatin, is associated this change of insulin resistance. So this is a very interesting study. This is a United Kingdom study for education program for prevention of diabetes mellitus. Totally about 18,000 individuals from 44 medical centers is included to the study, and about 1,000 patients have screening with pre-diabetes mellitus, and they organize education program with annual refresher and regular telephone contact. And would like to describe this conclusion. This shows the relative low resource pragmatic program may lead to reduction of type 2 diabetes mellitus and improve biomedical and psychosocial outcomes and is cost effects. So obstacles and barriers for prevention. 3 points. Economic problems is need some resource support. Social cultural problem is a big problem, for example, for India, for China, because when they have this rural lifestyle, this is good. When they remove to a big city, urbanization, influence American lifestyle, influence to the metabolic status too. Lack of data, knowledge, and skills. So is my conclusions, central issues for in type 2 diabetes prevention. Type 2 diabetes prevention must be integrated in a measure program addressing the prevention of other lifestyle-related disorders like cardiovascular disease and some cancers. It's the third main medical social problem in worldwide. Primary prevention is of the essence, especially in resource constrained countries. Diabetes prevention is an intersectoral effort regulating cooperation and coordination. Is a multidisciplinary problems. Diabetes prevention should be addressed within the context of health system reform, ensures the availability of acceptable health care standards. Culturally appropriate and economically feasible investigation should be adopted. Imposing unacceptable intervention will have negative impact. As my last slide is the confusion. The man who moves a mountain begins by carrying away small stones. Prediabetes is a target for prevention of diabetes mellitus, and it's our job for cardiologists because about 60% patients with arterial hypertension, cardiovascular disease have prediabetes. If we will diagnose this prediabetes, it will be good. We will prevention diabetes mellitus about 50-60%. If we don't prevention in the 5 years, every second patient with arterial hypertension will be patient for endocrinologists for type 2 diabetes mellitus. Thank you very much.